All right, I'm going to go ahead and kick us off. Thanks everyone for coming here in person, and for those on Zoom, thank you for joining as well. I want to welcome you to the inaugural health policy seminar co-sponsored by the Institute for Population Health and the School of Medicine. I'm Scott Shipman. I am the director of the Institute for Population Health and a member of the School of Medicine, so I can represent both of the sponsors up here today. We really feel at the Institute that health policy is a critical element of what we need to build and what we need to support across Creighton. If we really want to make a sustainable change in the health of populations, we have to recognize the critical importance of health policy in either facilitating or inhibiting healthy populations and health equity. Policy comes in a lot of different forms. There's legislative policy, which tends to make most of the news, but there's also very important regulatory policy. We have policy at a state level, policy at a federal level. We're lucky today to have a speaker who has experience on both of those levels and in both of those forms of policy. And we'll hear a lot more about that to come. One of our goals at the Institute is to build capacity across Creighton, from students to staff to faculty, in being effective advocates for causes they care about to advance population health, as well as to be well-informed about policy debates and the evidence to support better policy, helping to create that evidence and as well as helping to promote that evidence. Before I introduce our speaker, I want to give a shout out first and foremost to Ashley Carroll, who works with the Institute as well as with CHI as the Director of Health and Communities. Ashley has helped to spearhead much of our work in the policy space and has helped get this policy seminar series off the ground. Ashley has been supported, and I've been supported with our policy seminar advisory committee. We have several members of that group here, and we thank them for helping us get launched and helping keep us on the right path going forward with what we're anticipating will be a quarterly series of speakers going forward. We couldn't be more fortunate to kick off this series with our first distinguished policy speaker, Dr. Jeanne Lambrew. I want to give a little background, and the background will be abbreviated relative to what it could be, but I want to give some sense of the wealth of experience she brings. She's currently the Director of Health Reform and a Senior Fellow at the Century Foundation. From 2019 to 2024, she was the Commissioner of the Maine Department of Health and Human Services. And as commissioner, she helped to expand and improve affordable healthcare to more than 100,000 people, bringing the state's uninsured rate to its lowest point ever. She contributed to Maine's nation-leading COVID-19 response, including the highest vaccination rate of older residents and one of the lowest death rates in the country. And under her guidance, the state made historic investments in health and human services. Prior to that, she worked in the Obama administration in the first 2 years as director of the Office of Health Reform in HHS, and from 2011 to 2017 as the Deputy Assistant to the President for Health Policy. Prior to joining the Obama administration, she was an associate professor at the Lyndon B. Johnson School of Public Affairs in Austin and the George Washington University School of Public Health. And prior to that, Dr. Lambrew served in the Clinton administration in ASPE, the Office of the Assistant Secretary for Planning and Evaluation, as well as the White House National Economic Council and the White House OMB Office of Management and Budget. So a wealth of experience. Her background and training comes from UNC Chapel Hill, where she earned her master's and doctoral degrees in health policy. So without further ado, I'm going to hand it over to Dr. Lambrew.
Well, thank you so much for having me and for attending. I really am grateful for the opportunity. And it really does feel daunting to be your first speaker on this policy series. So I am going to try to do something large, which is to, first of all, contextualize the current health policy discussions. And second, distill lessons from the Affordable Care Act experience for future. Just to go for a minute to my perspective, most of it is from direct involvement. As mentioned, I worked on the development of health reform back when I was at the Center for American Progress, George Washington University, and the Clinton administration. In the Obama administration, I was the director of the Health and Human Services Office of Health Reform, helping to shape the legislation, figure out the estimates. When I went to the White House, my job was to oversee implementation of the Affordable Care Act and all other health policy for the 2011 to 2016 period, as well as help with defense that occurred, minutes after the bill was signed into law. I have done in my academic career, my think tank career, some analysis and review, but mostly from a health services research standpoint. I am not a political scientist. And I put all these lovely book covers on this slide because those are the real scholars of political science who've really looked at the passage of the law, what happened since, and why. My perspective is a little bit more idiosyncratic. So what I'll do in this time is on the left-hand side, do background. Define what is health reform from the perspective of this presentation. That's all it is. Really look at the history before passage of the Affordable Care Act. I spent a fair amount of time on that because I think it matters for the future. Then do a run through the passage of the Affordable Care Act all the way to present. Really kind of look at what's happened, as well as a really brief look at the results. We won't spend a ton of time on that because we really do want to go over the surprises. What did people who worked on it realize after the fact didn't go the way it was expected? What are the lessons you can glean from that experience for future health reform efforts? And going back to the idea of leaving with a hopeful note, what are the opportunities in the future? So try to do that with plenty of time for questions. We'll see how well that goes. So to start with, there are many ways to define the term health reform. I think most people consider it as ensuring universal health coverage. How do we develop systems for determining who is covered, what services are covered, how much to pay for covered services, whether that coverage is public or private, public being Medicare or Medicaid, private being private health insurance. How do we finance our health insurance and our health coverage? With Medicare, it's basically pre-funding. We all pay our Medicare payroll taxes while we're working to get the benefits when we're older. In Medicaid, it's a federal state matching program, which is pretty complicated, but that's the way it got developed. That's the way it works. And for most people in this country, we get our subsidies for healthcare, health coverage through the tax code. Not well understood. That is where a lot of money goes. How do we then, in terms of, after we get people covered, make that coverage affordable? Because affordability has always been a kind of keystone of health reform efforts. That involves payment rates. How do we structure our care models to really figure out how to best optimize people's health? Some people say it should be through competition. Other people say through regulation. There's a whole spectrum in between. But it's not just about how we pay for care. It's things like, what are we going to pay as a society for that breakthrough drug? How do we think about technology, be it telehealth or AI or any other technology? How do we think about the bricks and mortar of hospitals and clinics and mobile clinics? The infrastructure matters for affordability as well. I should say affordability and access. And utilization and efficiency are also things that drive costs. We have a lot of what's called prior authorization for fear that people are overutilizing or misutilizing healthcare. So that's one way to titrate utilization. Cost sharing is something that we're all familiar with, probably too much so, through high deductibles and co-pays, and that's another way that policy affects utilization and costs. And program integrity is something that's always been around, always an issue. Are we paying for the types of services that public policy wants, type of providers that are authorized to provide it, and is it being wasted? There are also other rules that often come under the umbrella of health reform. Public health, increasingly so, has been connected to our healthcare system appropriately, but it's been in and out over the years. Quality of care was a big deal in the Affordable Care Act. It still is a big deal, but how you approach that is variable depending on the reform effort. And equity is something that we really have in the past 5-10 years focused more on, recognizing that equal doesn't equal equal. You have to figure out how do we seek the outcomes that we want for all populations, recognizing that there needs to be disparate policies to achieve that. So this is just what we're going to be talking about in this session. Note more on the coverage part of it than the payment side, a little bit on the payment side, but just want to give a landscape and acknowledgement. It's not everything. There's other things that are in the Affordable Care Act, in health reform efforts, but just for this conversation, we'll focus it. And before we turn to the substance, I think it's important to remember why health coverage matters. We have a lot of research, decades of research on what are the outcomes for people who have some sort of coverage, any sort of coverage, versus being uninsured. We know that people who are insured have a greater sense of well-being. They're more likely to report excellent health. They're more likely to see a regular doctor for chronic illnesses and get their preventive services. They also tend to have a lower rate of depression. We know that death rates are affected by health insurance coverage, both the all-cause source of mortality as well as specific diseases like cardiovascular mortality have been demonstrated to be associated with having coverage versus not having coverage. And those data are fairly recent from the Medicaid expansion. So when a state like Nebraska doesn't have a Medicaid expansion, then expands it, we have a natural experiment to see how have people's outcomes changed. And we have really solid evidence that people's life expectancy and mortality rates improve with coverage. And we also know that racial disparities in healthcare often are driven by coverage disparities. So that's something else in here. This chart just shows a simple example recently of people who are uninsured are more than twice as likely, 3 times as likely not to see a doctor or health professional within a year because of their uninsured status. So now to health reform. It is not new. There have been efforts to pass health reform in the United States all the way back to Teddy Roosevelt on his Big Moose Party platform. It was actually not Franklin Delano Roosevelt. He did Social Security and a lot of the other reforms after that period of time. But it really was driven by the Industrial Revolution, where people began to realize that their workers need to be healthy, get health care, be back on the job. And that was the original motivation. Didn't go anywhere. And then Harry Truman was the next big champion. And he came at this from having been involved during World War II with looking at people who were being drafted or signing up to go to war, and the health status of poor people, rural people was so poor, a large percentage of those people could not actually go and be soldiers because they were too unhealthy. And for that person, Harry Truman said, why are these 16, 17, 18, 19-year-olds so unhealthy? That motivated him personally. At the same time, World War II also created employer-sponsored insurance. During World War II, we needed to build ships and planes and build things, and they needed workers. And so what Congress did way back when is say, we know you can't pay them everything you would like to pay these workers, but you can go ahead and take all their their benefits, health benefits included, and have them not be taxed. So it's a way of giving them a tax benefit for their health benefits. That's the origins of what is now the largest source of health insurance in the country, employer-sponsored health insurance. Didn't go anywhere, but fast forward, there was still interest in health reform when John F. Kennedy became president, but that interest began to shift to those who didn't have employer-based coverage, right? If people had decent job-based coverage, they didn't necessarily need it, but older people, when people were retired, when people were poor, single moms, people who were blind and disabled, those were the groups left out. And so that was sort of why we got in 1965 the Social Security amendments that created Medicare and Medicaid. It was really coming out of the gaps that got filled that were left when employer-sponsored insurance didn't take off. You know, another surprising champion of health reform was Richard Nixon. He was affected by the need for health care because his brother had tuberculosis, his mother was a nurse. It was something that moved him as an individual. He did try to do what now look like pretty impressive health reforms, but got bogged down in something called Watergate, so didn't get very far in that effort. And then the last big effort was Bill Clinton, who ran on this issue. I want to reform the healthcare system Hillary Clinton, then First Lady, led the effort. There's lots of good books written on this topic about why it failed, and we'll talk a little bit about that in a minute. But it did fail in 1994, which meant what was then a Democratic Congress became a large Republican majority Congress, and the pendulum swung way in the other direction. Newt Gingrich became the House Speaker. He actually said, no, we shouldn't be expanding coverage. We have too much health coverage. Tried to block grant Medicaid, tried to scale back on Medicare. He also failed. But out of that two-pronged failure on healthcare came the Balanced Budget Act of 1997, which not only did actually lead to the only balanced budget we've had in US history in the past 150 years or so, in year 1999-2000, because of Medicare cuts, but also created the Children's Health Insurance Program that exists today. So all of that matters as we go into the 2000s, and I'll spend a tiny bit of time on this period of development. So after Bill Clinton, was president, did the Balanced Budget Act, George Bush becomes president, he's focused on the Medicare drug benefit, all fine and good. But health reform at that time was viewed as impossible. I mean, you go back and read anybody's assessments in the years 2000, all the way probably through 2005, people said it was impossible, partly because of inherent challenges. Healthcare system is too big to change. It's like the opposite of too big to fail, too big to change, was what people thought. At that point, it was like 10% of the US economy was in healthcare. Now it's closer to 15, but it was a big deal. People thought it was just too hard to change. There was also a view that health professionals would tank it. They didn't trust government. They were afraid that any sort of health reform system would interfere with the practice of medicine. And in fact, at this point in time, the American Medical Association had never supported health reform. None of the professional associations supported it. We saw even groups like the American AARP, used to be called American Retired Persons, American Association of Retired Persons, always nervous about what would happen with health reform. So that was a factor. And then there was a real nature of people being anxious. So healthcare is really personal. When you have a relationship with a doctor or any kind of chronic illness, you care a whole lot about your healthcare. And that was part of the reason why the Clinton health reform failed. There was a set of advertisements run called the Harry and Louise series, and it was a couple, Harry and Louise, sitting around a kitchen table, talking about their concerns about what would happen to us as a family should this health reform pass. And that fear trumped the hope that people might have had for health reform. So that was the view, in addition to politics. For example, the Chamber of Commerce decided to go all in against the Clinton health reform effort in 1993-94, more as a political matter, not as a policy matter. They would have benefited from it, but they were anxious about the politics of it and really leaned in on one side. And the specter of socialism has been and was, remained out there. I mean, going back even to the passage of Medicare, Ronald Reagan was an actor in the 1960s, and he was in these advertisements against Medicare, saying that if this bill passes, the sun will set on a free America or something like that. It was very dramatic, but it was this specter of government takeover and socialized medicine being bad, and that's what health reform was. So that's where we began the debate that we're going to be talking about today. At the time, I was recruited to go work at the Center for American Progress, partly on this topic. How do we put this back on the map? I also was teaching and doing research. And our first effort was to develop a consensus. How do we do it? How do we figure out a way to address those concerns while getting everybody covered? So we developed ideas that built on what worked. So this idea of an employer mandate, meaning how do we maintain the incentives for employers to offer coverage so people are not fearful of losing their employer-based coverage? How do we create a Medicaid floor? I mean, it's hard to believe this, but back in the 2000s, we developed a bipartisan consensus that there should be some minimum eligibility level for Medicaid across the country, because it's not fair that somebody with 15% of income in Texas or Mississippi doesn't get health care versus somewhere like Massachusetts or New York. And the idea is, how do we create a federal floor for people in Medicaid? A third idea was, can we really make the private insurance system work? There was an idea called the three-legged stool. Require insurance companies to accept everybody. Doesn't matter if you have a history of cancer, doesn't matter if you have health problems, you should get an offer of affordable healthcare. But to make sure that young people with low income could afford it, give them financial assistance, sliding scale financial assistance to get everybody in. But the insurance companies said that's not even enough. We need to make sure if people get that affordability, if they get that access, they actually buy it. We don't want them hanging around on the sidelines until they get sick and they say, oh yeah, I'm going to sign up for healthcare now. They need to go to the hospital tomorrow. So there was something called the individual mandate, which was a Republican idea rejected by Clinton administration in 1993 that would say, again, if you can afford it, you have to get it. If not, you pay some sort of tax. Those were sort of the consensus ideas, plus nobody quite knew what to do with the affordability of healthcare. And so it was kind of what we call the kitchen sink approach. Throw it all in, spread it out, so no one sector, hospitals or doctors or drug companies bear it. Everybody should be contributing to an effort to get everybody into the system. So that consensus developed over a number of years along with analyses, because the numbers matter here. We developed multiple models that would estimate the potential cost and coverage of each option. How many people would get covered, how many people would move from one to another system, how much it would cost the federal government, people, etc. And that enabled this kind of dialing up and down these policies given different people's values or goals or budgets, right? And that mattered a lot. It also helped mitigate those concerns I mentioned. You could say, well, we've done all this work, and we think if you do this employer mandate and these types of policies, employers won't drop coverage. Or if you expand Medicaid up to this level, but not up to this level, you won't replace private coverage with public coverage. That was what all of this modeling was doing in the 2000s, developing that framework. That wasn't enough. We had to develop the imperative. Why? Why should people do this? One grounds is we finally really got the definitive answer on, is this a public health imperative? The Institute of Medicine did not just one volume, 6 volumes of research review and analyses on why being uninsured matters. I gave you a couple of those stats. They did 6 volumes of it. And that was a breakthrough. There was an economic imperative because businesses and budget people began to look at the growth of healthcare, which was taking away from wages. It was taking away from jobs. It was beginning to bog down budgets, state and federal budgets. So that imperative grew and was documented. And we also really realized that oftentimes people like me often focus on the technical answers and scientific answers, when a lot of it is values-based. We really worked on the fact that people do think healthcare is like education, is like public safety, something that people value. How do we make the moral argument? And indeed, a lot of the religious groups came to the forefront. Catholic Health Association was a leader, absolute leader in this effort, trying to say that we see people, we know this matters to them, we know as a nation we should do this, and begin to make that moral argument for health reform. That imperative mattered, but then the organization did too. Hard to believe, but back in the day, there was what was called Cover the Uninsured Day. Robert Wood Johnson Foundation funded it. It happened nationwide. It was on campuses. We all rallied every one day a year to say it's time to cover the uninsured. That was one example of this type of activity. A group called Healthcare Action Now, HCAN, really tried to connect the different groups. They would hold meetings with probably 100 different advocacy groups, state level, national level, talking to them, getting their ideas, sharing information with them, to really try to create a network out there that would be mobilized when the time came. And then there were the unusual ones. I staffed a group called Better Healthcare Together with Walmart and AT&T, the Communication Workers of America, SEIU, and their leaders, not just their workers, would go and meet with members of Congress to say, here's the principles, here's the why, we can work with you on the how, but this should happen. It was becoming an imperative. But because policy is political, we had to make the political case as well. Why is this not the third rail anymore? Well, we had help from Mitt Romney, who was then governor of Massachusetts, and they passed, with support from Senator Ted Kennedy, a universal coverage bill in Massachusetts, Connect Care, that today has yielded the lowest uninsured rate in the country. They led, other people followed. You might know Senator Chuck Grassley from Iowa, who's still in the Senate, Senator Max Baucus from Montana. The two of them got together to do a day-long Library of Congress teach-in on health reform, attended by almost like majority of members of Congress back in 2007. So there was a growing, we have to do this, we need to get together on how to do it, as well as some view that it was a politically winning issue. Partly that was because people started working on the midterm elections in 2006. I was one of many people who went out and hosted candidate forums just on health reform. So we would go across the country. I went to Ohio, I went to New Hampshire, and we just let people talk about health reform. It's an hour-long session. And when you think about it, if you're running for office and you're facing your constituents in a town hall meeting on one topic, you learn about it. You learn how to talk about it. You learn how to care about it. And that kind of activity made a difference. Healthcare popped into the reasons for people winning in the midterm election. And in fact, Nancy Pelosi became speaker in 2007, and she will attribute it partly because of the health reform effort that happened in 2006. And then in 2007, something happened that I've not seen happen since. If you recall, during the last presidential election, it was like one debate, and there was not any Democratic primary candidate forums because there wasn't a Democratic primary, and there were Republican primary forums, but they weren't fully attended. I don't think the president ever attended them. We had a session back in 2007 that was a day long, where every candidate had to come and talk about their health reform vision with a reporter, Karen Tumulty from the Washington Post, who was not shy about asking them the hard questions. That's different, right? But that was creating this idea of like, you have to get your act together. And then candidate Obama definitely said afterwards that forum made him focus more because he did not know how to answer the questions. Hillary Clinton did. And John Edwards did. There were so many people talking about health reforms. That is what you call political momentum. So, done with the preface. The door does open. So, in the 2008 election, candidate Obama won. He became president. The Democrats gained a sizable majority in the House and Senate, and they all viewed that health reform was now going to be something they had to do, and they were ready for it. Going back to this idea of getting all that work done. In the House, Speaker Pelosi decided that she couldn't have the bill divided up among 3 different people who are all going to butt heads. She created a tri-committee across the House to work together on it. She also replaced leaders. Like at that point, a person named John Dingell was head of the Energy and Commerce Committee. She didn't think he was passionate about it like she was. She put Henry Waxman in charge of that committee. It was controversial at the time, but then Congressman Dingell jumped on board and helped, Congressman Waxman get the bill across the line. That's leadership. In the Senate, the Finance Committee was ready with a white paper day after the election. Congressional Budget Office produced not just a paper, but 2 full volumes, hundreds of proposals, cost estimates, coverage estimates in December of 2008. So we had all that information at our fingertips as we were beginning this debate. And I was on the transition team for Obama. My job was this, the morning after the election at 9 o'clock in the morning. And a lot of other people were not answering their phone calls. I had my first health reform meeting because we had to start. We had no time to lose. We really needed to get on top of this. But as the heading of this slide says, it was during a storm. The recession had started. We had started to see banks fail, started to see the auto companies go under. Unemployment was rising. So we had a full-blown recession that was on our doorstep, and that was going to set things back. There was also this thing called pent-up demand. Who gets to go first? Is it climate change? Because there are people who are dying to do that. It's so important, and people want that to be the first issue. People worry about Social Security reform. How do we take on something important with this kind of majority? Immigration reform was something we wanted to do. We could have done it, right? Democratic president, Democratic Congress, we knew it was important, along with health reform. So that kind of pent-up demand created bottleneck. How do you figure out what goes first and how to do it? And we also had a new politicization. After that big victory, Senator McConnell said, Even if it's a bipartisan bill, don't support it. We have to make this guy a one-term president. And the view was, if this popular incoming president were able to achieve major change for the US, he would be unbeatable and they would usher in a Democratic majority for years. It's a political theory and it makes some sense, but it created a very tense environment for trying to get anything done, including with moderate Republican Democrats, because this is the way our world works. It's not just all one party or another. So it was challenging, but now I'm going to do the whirlwind through. We're not actually going to talk about the passage of the Affordable Care Act much because, again, that's a whole set of books here. But just to give you some milestones, so during the transition, we did community town hall meetings. In March, there was a White House forum. Again, all the Republicans in Congress, Democrats in Congress came, stakeholders came, and it was really a debate about how do we reform healthcare. We did regional forums too, just recognizing that not everybody can come to Washington. So did 6 other regional forums. The president went to the American Medical Association and said, you know what? We need you. This is our moment. How do you get you from opposition to supporting and really trying to mobilize our nation's doctors? Because people believe their doctors about anything healthcare, including health policy, even though I think these days, most of our medical students get some health policy training, but back in those days, it was not common. So they were expected to know a lot about health policy. So the president entreated American Medical Association to get on board, which they did. But things began to bog down. The Tea Party, which is a libertarian group, started showing up in August at town hall meetings with their "Don't Tread on Me" flags, going back to the socialism theme, talking about some parts of the bill being death panels. So if Medicare is going to pay for end-of-life counseling, that means that some government official is going to pull your plug. Not true, but it became a thing of counterbalance to the momentum that had been created for health reform. And because of that, the president decided in September to go do a joint address for Congress. It's fairly well known for one member of Congress yelling at the president that he lied about something on immigration. That's what people in the political pundits remember. But at the time, it's very well documented. President's speech, the attention it got, raised people's awareness of health reform, which is what mattered. And that's what he was always trying to do, is how do we move the needle? So indeed, we kind of got the House bill passed in November. The Senate bill took a lot longer, but it got passed on a bright, snowy December 24th morning in Washington, D.C. And things were looking good until the next month when Senator Kennedy's seat, because he had died the previous August, went from a Democratic person to a Republican person, Senator Scott Brown. So that meant, you go back and look at the headlines, health reform is dead. Can't pass it without that one vote. You need that vote. It's over. And indeed, having worked the night before the special election till 2 a.m. in the speaker's office, working on the bill, trying to get things done, the next day, all meetings were canceled and they were not reconvened for a week or two because people couldn't figure out a path forward. But if you heard, and I didn't write down the quote, people like Nancy Pelosi were like, if the gate's closed, we'll jump over the gate. If the door is closed, just some sort of quotes about jumping over things to get the job done. And indeed, President Obama was on the same page, convened a summit at the Blair House, which is the vice president's house across from the White House. One last gasp. Will you be with us? Why are you opposing health reform? How do we get this done? And then push it through. It helped that Anthem, the health insurance company, had announced that week or two around that summit that it was going to increase its rates by 43%. People were not happy about that. They were angry about that. So that constellation of events meant finally, it got passed on March 2009, 10, I should say. What were the results? We're not going to go through the Affordable Care Act's a couple hundred pages, but I think it's notable that there are 10 parts or titles of the law. Only the first 3 are about everything I'm talking about. First one was about affordable, coverage for everybody. Second was about efficiency. Actually, second was about public programs, and third was about efficiency. Those are just the first 3. But then there were 3 titles, one on prevention of chronic disease and public health. Sounds like it could come out of today's debate, right? Program integrity. We have workforce, a whole title on workforce. So it was a bill with lots of other things in it, even though we're focusing on this one. which I think is important in retrospect. It also was projected at the time of passage by the Congressional Budget Office to cover 95% of Americans. We always said we're trying to get to near universal coverage as far as we can get. That was what we thought we would get under Congressional Budget Office. We fully paid for it and then some. We reduced the deficit. We found taxes and healthcare provider payment reductions that providers agreed to. It was all being reinvested back into coverage, and we're able to achieve that mark. We also did have the Congressional Budget Office say we're slowing healthcare growth. So at the moment of passage, it was a big bill, but it covered what we needed to do, and we thought it would do what we set out to, which was very exciting for a day. But the same day, we started getting all sorts of challenges. So again, this is going to be the run through what happened next. So this is a very quick timeline of the rest of the Obama administration. So day before the bill got signed, day after the bill got signed, we started working on what are called early deliverables. The idea is we had to have in the bill things that would be available and prove to people that all this effort was worth it, because many of the bigger reforms, as you can see over here, the insurance reforms, health insurance marketplace, wouldn't come for 4 years. So that included giving older people a discount card for drugs. We're going to do more on prescription drug coverage in Medicare, but that would take time. We gave them a card. We created a program called the Pre-Existing Condition Insurance Program. So all the people who have pre-existing conditions who couldn't get coverage, they're like, I was supposed to wait 4 years. We created a temporary high-risk school that was well-funded, accessible, subsidized for those people 3 months after the law was passed. We'll talk about that in a minute. But we had a bunch of those that are called early deliverables, ways to prove to people that we were immediately trying to help them. That was actually the very exciting thing we did. We decided to front run it, and insurance companies agreed. We started covering adult dependents on their parents' plans within a week of the law being signed. We're supposed to do it within 6 months. But we asked all the insurance companies, they said, look, we agree. So we got as many young people onto their parents' plans as we're waiting for things to kick in as possible. One of the most popular provisions of the Affordable Care Act. Those are the early deliverables. We then worked very hard for the major reforms to take place in 2014. The health, that three-legged stool, the health insurance marketplaces began then, the insurance reforms began then. And it wasn't just for that people back coverage. Every person with employer-based coverage got preventive services coverage, got an out-of-pocket maximum in their plans. We eliminated what used to be called annual limits. People who get coverage and then find that they ran out of coverage within a year. That all happened in 2014. And then by the time we're at 2016, most states have expanded and complete. But going back to what I said earlier, the whole idea was to create a nationwide floor for Medicaid. So it wasn't going to be Mississippi and Texas here and New York and Massachusetts there. Go back to the bottom part of the chart, which are challenges, and these are just a few of them. After 2010, as much as we tried to get the early deliverables up and out, by November of 2010, we didn't. And the Republicans beat the Democrats in Congress. So it would have been a Democratic control of the House and Senate became Republican control of the House and Senate. And their first bill, called H.R. 1, that's what you call the first bill in a year, was repealing the Affordable Care Act. So within not even 9 months, we were faced with our first of what became 60 bills to repeal the Affordable Care Act. Probably 40 of them occurred in this time period from 2011 to 2016, and President Obama vetoed them all. But obviously, as we get to our next chapter, was worried about what will come. The day that the president signed the Affordable Care Act into law, Virginia sued, and then it became a big case called NFIB versus Sebelius, went to the Supreme Court suing over the Affordable Care Act, saying, number one, that provision that requires people to have coverage or pay a tax if they don't is unconstitutional. You can't force people to buy health insurance. You can't force them to eat broccoli. Unconstitutional. Second, that Medicaid floor that I talked about, that is coercion for states. You're going to take away all the states' Medicaid money if they don't do your Obamacare thing. That was their second claim. And a third claim was there's no what's called a severability clause. I'm not a lawyer, but I learned all about this. Severability clause means that if one part of this bill is deemed unconstitutional or blocked by the courts, the rest of it's okay. That means it's severed, like you sever that one thing, like the individual mandate's unconstitutional, the rest of it's okay. There was not a severability clause in the Affordable Care Act. So when we went to court in 2012, it would have been that the whole law would fall if they deemed that third argument was right, that there was no severability clause. So if one thing is infirm, the whole thing goes away. I'll just fast forward and say, John Roberts was the deciding vote and said the Affordable Care Act mandate was constitutional under a taxing clause, not under something else. They did decide that the Medicaid expansion had to be a state option, could not be a nationwide floor. And we did avoid this issue about severability, but just to give you a sense of how vulnerable things are, my job, I was at the White House at the time, was to plan for the worst. So I had to have a plan, because the way it works is the Supreme Court would rule in June, it would remand it to the lower courts, which would have to act within 30 days. And in 30 days, the government would have to act on the decision. I had to have a plan to take away all those drug discount cards, to shut down that program that was covering 150,000 people with pre-existing conditions, tell insurance companies to stop covering young adults, take home health aides out of homes because we had funded that with some early money. That's what you have to do in these decisions. So just keep an eye on some of this as you're going through. This opposition is not just political, it's not just optical, it's absolutely real. But we got through that challenge. And then we had another challenge, which, as a president would say, was our own fault. As we're going to launch our health insurance marketplace for January 1, 2014, the website crashed. Healthcare.gov is kind of famous. Again, many books written about it, much to be said about it. I was on the list of top 10 people who should be fired for not making sure Healthcare.gov worked on the first day. And indeed, I offered my resignation because that's what you do when things don't go well. But we had a team of people who worked on it and got it fixed. And we actually hit in 2014 the exact number that Congressional Budget Office projected we would cover in March 2010, which is a huge relief. But these are challenges and setbacks that matter, because at every step of the way, what you wanted to do, what you tried to do, was slow down, stop, or redirect it. And as we come to lessons, I think you'll hear more about it. So that was the Obama years. But what we know what happened in 2016 is Donald Trump won. And there had by then been a Republican Congress since 2011. But now was a new administration priority. That HR 1, the first bill to repeal the Affordable Care Act, is now put your money where your mouth is. Now you can do it. If you have the president who supports it and you pass it, you can do it. But it was just a repeal bill at first. So they thought, well, maybe we can repeal it and figure out what to replace it with. What's called a repeal and delay. Repeal it for 2 years or something like that, and then come back and figure it out. And it was kind of not sensible. And even the Republicans were like, no, we can't just repeal something with nothing there. Then it was a repeal and replace, but they really hadn't done a lot of work on that bill. So it was called a skinny bill, going back and forth in the spring and summer of 2017. Back then, members of Congress, especially the Senate, said, I need to see those numbers first. When the Congressional Budget Office comes in and tells me the cost and coverage implications of this bill, then I'll figure out if I vote on it. They demanded it. CDO said that 20 million people would become uninsured under the repeal and replace bill, which meant Susan Collins from Maine, Lisa Murkowski from Vermont, and then this famous moment, John McCain at 2 a.m. in the morning did a thumbs down and decided to vote against it. It killed that bill, and even though there were subsequent efforts by Senators Cassidy and Graham, they never got the vote. Just as a color on this particular vote, just to prove that this was work. Senator McCain that afternoon did a press conference with Senator Graham on their plan to do their own version, but he changed his mind at 2 a.m. because of the other people who were noticed. So health reform was, on hold again until we're now up to the passage of the law. So we know that at the beginning of the pandemic, people got free, widely available testing and vaccines through any sort of mechanism. That's sort of what we did, was we just tried to make sure it was ubiquitous. When I say we, Trump administration in 2020 and Biden administration in 2021. This is, again, not a time when this was part of. Then we decided to suspend people being checked to see if they were still eligible for Medicaid call redeterminations, because we didn't want somebody to become uninsured in the middle of the pandemic. Thought it was temporary. It lasted from 2020 to 2023. Then we had this start of redetermination called unwinding, where we had to go through and check every single person on Medicaid to see if they were still eligible. It put a real sharp focus on how messed up our eligibility systems were. So lots of reforms to improve Medicaid and the marketplace. And at that point, they almost filled the gap in Medicaid in those states that hadn't expanded Medicaid. They were a couple of votes short from having the marketplace fill in the gaps where states that didn't expand it, but it just didn't come to fruition. On the marketplace side, they did actually lift the cap on eligibility that was put into place. Again, Obama wasn't all that happy with some of the Affordable Care Act parts, including we had this artificial cap at 400% of poverty. You can see it. So somebody's percent of income that they pay for health insurance was that yellow line, then it jumped to 20% of income because of that eligibility limit. The American Rescue Plan, Inflation Reduction Act created this green line, which was more generous for low-income people, and then just phased it out. That is actually in effect today. It expires in December, but as we'll talk about in a minute, made a big difference. So now we're to 2025, and then we're going to begin our lessons. Taking longer to go through than I thought it would, so I apologize. But I think when Trump came in, he gave an interview in December that says, I don't want to do that whole repeal and replace thing again. Like, didn't work out well. Unless we have the votes, we're not going to do it. Not going to do it. He said that very clearly. But the budget reconciliation bill, also previously called the One Big Beautiful Bill, did purport to extend the 2017 tax cuts. So it's a lot of tax cuts that got extended, funded Homeland Security and Defense and other things, did not extend those premium tax credits. But there was a demand that it be paid for so it wouldn't increase the deficit as much as it did. So there's a lot of cuts to education and nutrition, but also healthcare. There's over $1 trillion in cuts over 10 years to federal health spending for healthcare. Proponents say it is not repeal of the Affordable Care Act. There's no rollback of the ACA eligibility extension in Medicaid, except for illegal immigrants. Work requirements are not eligibility change. They're making it an earned benefit. And anybody else is seeing coverage is because of program integrity or caution to states that were doing this. So that is the argument. But I'll say that we know that the law does indirectly target the ACA. When you rack up all the cuts in that bill, in that law, I should say, plus what they didn't do is a 40% cut in marketplace subsidies. That's a big cut for people. You're seeing some of the premiums that are going up next year in the marketplace. It's because of this, not an accident. We also know from Kaiser Family Foundation that of the $911 billion in gross Medicaid cuts, $526 billion apply targeted to states that extended Medicaid. So I think it's fair to say that whereas the largest cut in health spending in U.S. history is actually disproportionately going after the Affordable Care Act, and it will undo the main goal of covering all Americans. Congressional Budget Office estimates that by 2035, there'll be 10 million more uninsured, most of those in Medicaid, but add more from the marketplace because these tax credits has a 50% increase in the uninsured. And I'll just say as a note on the right-hand side of this chart, I talk a little bit about like the comparison. Is this a healthcare bill? Affordable Care Act, we had 7 public White House sessions. We had 153 bipartisan amendments. We had 40 to 50% of people supporting the bill. Not great, but not bad. This bill in June had no public sessions, no bipartisan amendments, and only 27% of people supported it. And whereas the Affordable Care Act covered 32 million more people, this would reduce coverage by 11 to 16 million. And the impact of the deficit is, again, diametrically opposite. Affordable Care Act lowered deficit by 143 billion, and this new law would increase it by 2.4 billion. So it's just a contrast, not a healthcare bill, but has healthcare implications that I think will beget some changes. So where are we today? Just the results. We have lowered the health insurance rate in the country. This chart is through 2023. Just today, while we're talking practically, Census Bureau came out with the numbers for 2024. It's basically the same, but that's before this year. We know for kids and for seniors it's higher, and for states that expanded Medicaid it's lower. We probably would have achieved that goal if all states have expanded Medicaid. We do know that access has improved, and on the healthcare cost front, no, we really haven't seen health spending increase as a percent of our economy like it did in the pre-ACA period. Medicare spending per capita has been level, but that's begun to change. Hard to say if that's the Affordable Care Act or not, but we've seen a trend change. So what is surprising from this story? Some of this is not surprising for all of us who worked on it. We knew we threw in a lot of things to help get it passed through Congress. There was a long-term care program called CLASS, this co-op program for nonprofits plans. They got repealed as well as the 24 other provisions. There were gaps, unfinished business. Obama felt strongly before he left about writing a piece in Journal of American Medical Association about what he thought needed to be done, what worked, but what needed to be fixed, including the inadequate premium tax credits. And we kind of knew there was not going to be a lot of opportunity for improvement. But we didn't expect the pushback on the savings. So many of the savings proposals got repealed. All the ones that are called game changers, the ones that were supposed to be innovative and different, Independent Payment Advisory Board, tax on these catalog plans, all gone. And then they hamstrung some of our more important tools, looking at outcomes for patients and comparative effectiveness research, as well as innovation, all got constrained after the law passed. We did continue to get savings, but even with Medicare Advantage, what we thought was going to be savings, with that red line there, became actually a cost as most people enrolled in Medicare Advantage. So we're surprised we got savings. We shouldn't have, because things have gotten unraveled. We also were surprised by how well those premium tax credits worked. We worked hard to design before it got passed. And indeed, in response to Trump changes and Biden changes, it adapted. So it's a long story, but Trump kind of did a rule or a policy that lowered subsidies in the marketplace called cost sharing reductions. Even with that, premium tax credits adjusted. And then once those tax credit improvements came in, look at that dramatic rising moment. It doubled after those tax credits got approved, showing that that policy was helpful. That whole individual mandate that we slaved over and was very controversial, we prioritized it. We thought it worked. We thought the insurers needed it. Yet it was hard to get Democrats on board with that as well. But now we know, since it got zeroed out in 27, the same tax cut bill that just got extended, got rid of the tax as part of the individual mandate. 5 states adopted it, even though they did that, but then we had the pandemic and the other things going on. But the Affordable Care Act survived. Even the insurers these days, maybe not with it. Big threats. A lot of extra work for our small programs, those early deliverables. I mentioned that pre-existing condition insurance program. It only ran from August 2010 to 2013. And we counted them up, 1,600 actions. We had that many policy decisions to create it, change it, adapt it, change it, create it, change it. It was an incredible amount of work. It covered 135,000 uninsured people with pre-existing conditions. The chart in the slide shows you how variable it was across the board. But in one page of regulation, we eliminated pre-existing condition exclusions. The insurance companies actually liked it because they got rid of whole underwriting departments they had used to do medical screening and the complaints about people saying I should get coverage. And it helped 3.9 million people who were uninsured with pre-existing conditions. So it was a lot of extra work for programs versus fixing the existing policies. We also were surprised by not just ongoing, but often irrational opposition to what continues to be called Obamacare in some circles. There was that litigation I mentioned, which would have harmed people across the board, no matter what their political persuasions. But even to date, we're still in litigation on the Preventive Services Act in a case called Braidwood that is trying to take away the ability to link how we cover preventive services to what experts like the Advisory Committee on Immunization Practices or U.S. Preventive Services Task Force, all of which are being dismantled by Robert F. Kennedy Jr. But the law was designed to be adapted to science, and that's still being challenged. Again, it doesn't make a lot of sense. Most of the people you talk to agree with that. Similarly, on the legislative front, states have refused to take money that would benefit their people. It's just almost free money, and yet we saw, because it's Obamacare, they wouldn't take it. And again, fast forward to what just happened in 2025. the loss of premium tax credits I just described, Texas and Florida are the states that are going to be hardest hit. These are not states that supported the Affordable Care Act, yet their support for this law and their enmity towards the Affordable Care Act is going to have their residents, their citizens hurt. And even the states that have passed Medicaid expansion through ballot initiatives will be affected. People like Senator Josh Hawley tried to argue for some sort of carve out for the ballot initiative states like Nebraska, but didn't happen. So I'm almost done talking. What does this lead us? Where does this lead us? Just a couple things I'll say on planning and then on passage. On planning and readiness, do the work. I know that sounds like, trite, but the amount of work to get ready for that moment when that moment opens is enormous, and there's never enough that could be done. The best idea doesn't win. You need to have a comprehensive and coherent and complete set of proposals that work together. You need to develop a consensus around it and note that that changes over time. So a public plan option was a very controversial thing back in 2010 when we were trying to pass the Affordable Care Act. I spent so much time working on one because we thought it was going to be included. Didn't get included because of one senator who decided in December of 2009 he didn't support it. That idea is back. Controversial then may not be controversial now. We have to be adapted to that. Consensus is needed, but it also adapts over time. And you need to figure out a way forward, not just the best plan, but plan B and C and D and fallbacks, because you never get your first plan. It's the nature of any sort of real world challenge, including on how to get from here to there. There was a debate, I can't remember who was debating with Bernie Sanders, but somebody kept asking Bernie, how do you get from here to Medicare for all? And he didn't have a good answer. And it was one of those things where get an answer, right? Just get an answer. You need an answer to these questions because it undermines your vision if you can't figure out how to get there without waving a magic wand. And connect the values, especially now. We're in an environment where people are skeptical of science and motives and distrustful. I think the values equation matters a lot. But when it comes to actually getting into the legislative process and trying to work on it, compromise when you know it's going to matter, not just because you think it will. We included so many policies in the Affordable Care Act because we thought they were compromise policies. They weren't. It was a waste of time and energy. We did focus on fundamentals like those tax credits. That's especially true now where the courts are not letting you do a lot of regulation. Improve programs, don't just keep adding them on. This idea of just continuing to slap on and patch our system is not working. We all know that. We have a system that's way too complex. Complexity itself is a barrier. And recognize that even securing those small changes maybe is far as difficult as it is. I had been talking to some friends in Congress, maybe we can get a new out-of-pocket maximum for people with cancer. That would be as hard as trying to get an overhaul of trying to align Medicare, Medicaid, and private insurance, mathematical costs. These are the big things, not just for the small people, the small population issues. So I'm going to end on my optimism. I hope that these lessons are helpful because I think we're going to have major changes in the coming months and years. Why? Because remember that anthem story I told you, 43% things? They're back. While general inflation is currently 3%, the business non-included reported 2 weeks ago that employer premiums are going up 3 times as high, by 9%, and marketplace premiums are going up by 18% next year, and that'll probably be higher before we do. People are really concerned about medical bills and debt. This chart on the right shows you of all people, this is taken in July. 23% of people say they have problems paying for healthcare. 36%, 1 out of 3 people have skipped healthcare or delayed it because of costs. And 44% of Americans think it's difficult to afford healthcare. That's a crisis. And there are going to be opportunities. States are going to have to act. Some are calling special sessions right now. I was reading it this morning. Some will do it in January. They will have to act this year. They'll have a chance to think hard. Can we make changes to implement this bill? Are there big ideas that we could adopt? We also have a midterm election coming up in a year. Will there be ideas that are put in versus just roll back, which has got passed? What is the positive vision for change? And we are not far away from the presidential election. I know it doesn't feel that way, but going back to that timeline, now is the time to begin. I am optimistic that we're going to see some major changes, some in states next year, some big ideas maybe coming around in the midterms. If next year is a healthcare election with people voting because they care about healthcare and things changing Congress, there may be a beginning of efforts get here, but I think the real change will come when the president and Congress recognizing that it's time again for big health. So with that, I will stop. Thank you for having me. I appreciate it. I think we have a full half an hour of discussion, is that right?
Yeah, we do. We have plenty of time. So we'll open this up now, both for those in the room. We'll start there. We have Ashley is keeping an eye on the chat for those who are virtual. Please post your questions within the chat and we'll get those asked. Any questions right out of the gates that anyone wants to pose? Yes, Dr. Lydia.
Wonderful talk. Thank you for that quick run through history.
It was a long run through. Sorry.
A lot of stuff. What do you see as the biggest changes that any state could make, and how important is it for a state to be a leader in creating something novel?
Great question. The downside, the negative for states is as follows. States control less of health policy than the federal government. So, for example, their ability to change Medicare policy is next to none. Their ability to change coverage policy for employers that are self-funded is also non-existent. But there's a belief, and let me just keep going. And this new law limits their revenue. It's not a strong revenue time. So it's not like they have pots of money that they can go and solve the problem. And even if they did, it's time limited. The positives are that prices have grown. We have seen, hospital inpatient outpatient prices, partly through consolidation, go up. There's some room for some state action on outlier pricing, which if they did that would lower insurance costs as well. We know that would lower state employee costs. It could offer some savings for states. At the same time, if you're going to tackle high prices of hospitals, can you go after the insurers? Is there more we could squeeze out of our insurer relationships? Too many middlemen, use of PBMs or pharmaceutical benefit managers that are not good. Can we improve the efficiency of insurance companies? I think there's room there that states might be able to get that funding in. And we were talking about before the session, there's this Rural Health Transformation Fund dollars that are coming before most of the other One Big Beautiful Bill funding cuts. They come next year. The application is going to be coming out today, approved by the end of the year, and states can use that to simultaneously work on the systemic problems in rural areas, which is why oftentimes we see the hospital prices are high while figuring out how do we get at some of the true cost drivers. So I think creative and innovative states can do this. Colorado's done this in the past. Washington State's done this in the past. We have 9 states now that have taken this reference pricing approach in their state employee health benefit plans. I think states can be very creative, including looking at public plan options with these insurance company prices going up high. Not a ton of options for states, but I think they'll be the vanguard as they were in the past. They're often the so-called laboratories of democracy and are the first ones that try things out and give political and policy courage to Congress.
Yes.
Hello, wonderful talk, and really appreciate your hope. One of the ongoing criticisms of the ACA and of all current, and I'm speaking from a physician standpoint, it has been the lack of any discussion of tort reform in how do you control costs. Fear of malpractice, and I was a military physician for 40 years. I didn't have to worry about malpractice. I did the correct medicine for the right patient at the right time, regardless of the costs. And there's no doubt that everybody's looking over their shoulder in the civilian world because they can't do the right medicine because they're either going to get sued or their business practice is going to say, well, wait a minute, patients are leaving you, or the federal government is withdrawing payments. And so what am I going to get paid? So the business The business managers of practices are on the back of the physicians and the healthcare providers. The patients are not happy and can sue for anything. And so you're driving up costs. So it drives bad behavior in physicians and healthcare providers to provide unnecessary care. It incentivizes lawyers to chase ambulances. It really is a problem, and it's totally has been unaddressed in tort reform and in the healthcare management. And maybe that's because lawyers write the laws, primarily. Any thoughts?
I agree that has not been addressed. There's been some states that have tried to do it in various levels of success. I don't think that there's one state that you can look at and say, aha, they figured it out. We don't have great experience, I think, from states. But it's a good question. It was part of that CDO, Congressional Budget Office, help options way back when. But your point's well taken. I don't remember the last discussion I've been in on the topic. And it's good to put in the list. These are the sorts of things, like again, going back to what are areas that we might be able to do in this world of tackling healthcare costs when we don't want to do it by throwing people off of Medicaid or Marketplace. I think these ideas will have more fun.
Dr. Lambrew, you mentioned that in a couple of years it may be another chance for more major reform, and you encourage us to think big rather than thinking small when we think about reform. What would be the top 3 things if you were writing the next legislation for major reform that you would prioritize?
I'm not done with my homework yet. So since I said your homework, I can't give you good answers. I can say where I think the energy is. Medical bills and out-of-pocket costs for people who are insured are just so high, as is the complexity of navigating the healthcare system. A few of my colleagues and I were meeting at the end of the month to revisit, why do we need deductibles in healthcare? It's an old-fashioned 1950s creation back when the way insurance used to work was like, you pay a certain amount, then insurance pays everything else, to kind of get away from moral hazard where people just gonna jump in and use everything. We have a lot smarter ideas. So I think reforming how we think about costs. So if people are covered, they get healthcare. So I think that will be on the horizon. It'll cost money, but actually if there's smart ways to think through, again, the marriage of that with other things, that will be there. I think that people are really fed up with the fact that, well, it feels really bad for them. There's still insurance companies and drug companies and even hospital systems that are quite profitable, and you just can't get away from those data. It bothers people. And I think that trying to figure out how we can rein in excesses, and I would say that does include, if there's med mal lawyers who are making a lot of money out of the system, how do we get people to feel like it's a fair deal for them? Because that's, I think, the motivation of a lot of people, is that some unlevel playing field, we need to get at that. I would say the third thing, though, is going back to these programs. With simple fixes, we can make Medicaid a better program. With simple fixes, we can make Medicare a better program. And with simple fixes, we could get our private insurance both working across the board better, as well as with Medicare, Medicaid. I know that sounds Pollyannish, but I think that's the direction we need to go in. How do we truly create a system out of the patchwork of the U.S. health system, which again, I don't deny the fact that ACA made it better in some ways, but not in others, and it made it more complicated in some respects.
Thank you so much for your talk and for all your work you've done over the years for the healthcare reform. I wondered if you could maybe ease my sense of impending doom on the finding of the U.S. Preventive Services Task Force and the impact on coverage of preventive services.
We're also discussing whether bellwether already is registering the practices. My state of Maine right now is the government our laws. Again, it's confounding to me because our way, going back to that original concern that we don't want government getting in between a patient and a doctor, was why we created a link between what you get for prevention to a group like the U.S. Preventive Services Task Force, because they are nonpartisan experts who look at the evidence. I mean, if you've ever spent time with some of those folks, you will learn more than you want to know about prevention because they will tell you every study, every gory detail. They have piles of studies they look at every time they grade a apparatus service to figure out if it should be covered or not. The whole goal was to make it be a smart policy, and that I think that model is now on. I don't know what the true long-term alternative is, but there are certainly a lot of, look at alternatives at the state level, which is not perfect. There's discussion of litigation. I just will say that because, I mean, there are ways that things got created, like U.S. Predators Task Force, that recently a court put up. It's like, it's not like we're without defense. So I think it's an all of the above strategy. I will say, going back to kind of this future preparation for future health reform, I think people need to work on how do we reinvigorate trust in different institutions so it's not Congress writing into law what preventive services you get, which is what's going to happen in the absence of something like an alternative to the model that we created. Maybe we can go back and fix what got broke. I don't know. Other countries have done it. Like, UK has NICE, the National Institute for Clinical Effectiveness. I think it's an organization that's out there. There are other models we're looking at internationally, but I think it's just going to be trench warfare with a small caveat that it takes time for everything to cycle through the system, and insurance companies actually recognize the value of preventive services, so they're not going to be quick to drop it as they could otherwise be, but it's a risk.
My question is about your talk on equity and individualized solutions. How do you balance that when you're talking about like large national health reform to allow for that like individualized innovation while addressing 300 million people?
That's a good question. Yeah, I think that there's, without a doubt, in public policy today versus 15 years ago, a recognition of how do we do, I'll just call it top down and bottom up. Bottom up is really trying to empower communities to be the coordinators at a minimum, caregivers to the maximum, healthcare providers and professionals, in an ideal world. Building that kind of community up kind of infrastructure and recognizing the need to support them more. I mean, I know my work in Maine, we tried and failed, and finally we're figuring out the right models to get our ethnically based community organizations to get training to become providers, be able to fill out the forms, the paperwork, the requirements that federal grants and state grants come with. It's not easy, but that kind of bottom-up approach is something I think can easily be built into a national health reform model. And top-down is outcomes. We spent a lot of time, to a minor example, but I think it illustrates the point, on hospital readmissions and healthcare, and some of the other measures we use to pay hospitals. Because some would argue, if you're a safety net hospital, you're going to have people coming in with readmissions, for example, that are because they are unhoused or they don't have an ability to get the script because they have transportation. So they come in, and how do you figure out, in that frame, how to balance our outcomes with our interventions? And in that case, we were trying to work on models where we would give incentives to hospitals to go to those communities, to invest in those social supports so they could improve their readmission rates. That's a good example of an outcomes-based policy that modifies resource allocation to get at what you're trying to desire. I think that's more common in our health policy today. Currently work with a guy named Cody Kinsley, who used to be Secretary of Health and Human Services in North Carolina. He spends all his time thinking about this. There are ways to figure this out, but we all need to get a little bit more research and scholarship and then precision about how we do it so it doesn't become an overly broad intervention that dilutes its results, which is what's kind of happening with diabetes prevention program, for example.
Just a reminder for everyone who is with us virtually on Zoom, feel free to add questions into chat, and we are keeping an eye out for those.
Thank you, Dr. Shipman. And thank you, Dr. Lambrew, for distilling so much information in a great presentation. First, want to just start with an acknowledgement, right? That we are celebrating the 15th anniversary of the Affordable Care Act, which greatly expanded access to healthcare for millions of Americans. At the same time, we're talking about the prospect of 10 million Americans losing health coverage over the next decade, right? So I want you to help me think about the notion of consensus building, right? And maybe affirm my theory or refuting and give me direction in the thought that as more people, as health systems have more uncompensated care and lagging reimbursement from government-sponsored health coverage, or patients receiving their healthcare through government-sponsored programs, those costs also are translate to the commercial market too. So in essence, no one is left unscathed, right? If millions of Americans and thousands in Nebraska are losing their healthcare coverage. So just in the spirit of like coalition building, and how do we frame this issue in a way that invites folks to the table to think productively about solutions, particularly in a largely rural state. Half of the state's population is here in the Omaha metro, right? We have some unique challenges. So I just wondered if you could reflect on that.
I will say, I think, and let me talk a tiny bit about the bill and its passage, because, I worked to stop the inclusion of those healthcare cuts in this bill, and I failed, right? I failed, I did not succeed, people like me did not succeed. Partly it was because it was part of a larger bill that had debt ceiling in it, and a whole lot of tax breaks that people wanted a real deadline because of the debt ceiling, and the healthcare stuff was part of it. Part of it was the Congressional Budget Office estimates didn't come out until 2 weeks after the bill was signed into law. I think you didn't see the same sort of like focus on that. I think it's going to be like I talked about with the ACA, where the hard healthcare savings proposals got repealed. I don't think they're going to last. I don't think the premium tax credit cuts are going to last into next year. I think they're going to come back in and try to do something about that. And I think when Medicaid work requirements begin to get detailed, they're going to say, why does somebody need to prove that they work to get healthcare when they need healthcare to go to work? It'll be a flipped model, I think, where people will say, wait 1 second. We think that healthcare should be something people get, not because they work, and how do we mitigate this? I think there's going to be a values-based debate that will come around with Medicaid cuts. And I'll just keep going. I just have a feeling that the anger at, not going after some of the big kind of cost drivers. I mean, not $1 of the one big beautiful bill, what do you call it, the big beautiful bill act, came from the pharmaceutical industry. They punted on it, and they actually expanded a loophole in Medicare drug negotiation for certain orphan drugs to not be negotiated, right? There's real money there, right? Insurance companies, no Medicare Advantage cuts, they've documented overpayments for certain Medicare Advantage plans. They told the insurance companies they don't have to tell people next year how much their premiums are going up. They waived the notices that's supposed to provide this fall. So all of that between I think the immediate premium increases from tax credit, lapsing and problems will get repealed. There's lots of discussion about that in Washington right now. I think when work requirements come around, I think the value-based debate is going to come in. And I think going back to this populist sense of, some people are profiting in the healthcare system and we're hurting. How do we get at that? We'll create at least tables for people to talk to each other. And I'm hoping those tables are inclusive, from the communities that are suffering disparities to, the physicians who are frustrated with the system, to the hospitals that are on the front of getting the uncompensated care. That's the sort of activity that, was happening in the 2000s that I think can happen again as we go into the next, not even far distance. If you asked me a year ago, what is the next health reform debate is 5, maybe 10 years away, I now think it's 2, maybe 3, maybe 4 years away, because of all the catalyzing changes happening right this second.
We'll go to an online question.
The comment, it starts with the comment. Seems like we're living in an upside down world. Can you elaborate further on how values can lead us through these challenges?
That is a great, hard question. I can't answer that question very precisely. I will give you examples from the dark moments when I felt sort of the same way. Like, I'll go back to the Supreme Court case in 2012. You know, on the, like, those dark mornings where I had to go to work to figure out how you take, I mean, it's one thing to try and fail, tell people. It doesn't feel good. You feel like you should blame yourself. Should have tried it, just like this bill that passed this summer. What I could have done, what I should have done, etc. That's different than having to take something away from somebody. Say, we're going backwards, right? Like, we're literally, I'm responsible for moving backwards. That dark moment, the dark moment when the website weren't working and people were literally putting applications for health insurance on paper and sliding them under people's doors at home because they knew we worked for the federal government, saying, I need healthcare, give me my healthcare. Like, those are dark moments. But the sense of community that forms around them, people's willingness to help, their then willingness to figure out problem solving and solution finding is extraordinary. You all probably experienced this in COVID. I mean, there must be moments you experienced during the COVID pandemic where some neighbor, some friend, somebody did something over and above because it was the right thing to do. I think that happens in these upside down times, and I think we're about to see a whole lot more of it. I'd like to see some more leadership on that. I don't know where those leaders come from. It might be a community-based leader. It might be a state-based leader. I am hoping we see more clear articulation of the values about we should find ways to save money and be for program integrity without taking somebody with disabilities healthcare away from them, or an older person, or somebody who has no other choices. I mean, I think we can get there, but we need to figure out in those moments of crisis how to create the table, the community, how to then figure out ways to pitch in both for the individual and the system, and then figure out how to harness that into a larger movement. It's coming. I just don't know how quickly.
Scott, there was a question that was.
And I will just say we're looking for questions. I think it will come because of the charts that we do. We got to a really good place. I mean, the problems that existed in 2009 no longer exist. I mean, talking to people with a kid with, leukemia or some disability, worried that their kid would grow up and not have healthcare because they couldn't afford it, or they might die and they wouldn't be able to take care of their kid. Heartbreaking stories that don't happen anymore. And I can just flip it around and tell you all the people I've met who say, but for the Affordable Care Act, I couldn't be here doing what I'm doing. That inspires hope. It really does. And even over the weekend, talking about public health. Erin Carroll, who is the head of Academy Health, wrote a piece in the New York Times on Sunday that I thought was really thought-provoking. Like, our kids are actually healthier. All this talk about our kids are sicker or more chronic illness. He went through the history of our research and how we've been able to tame some of our infectious diseases. We don't have as many kids dying of RSV. We've been able to limit accidents for kids, which used to be a major source of childhood mortality. I mean, we have to just continue to look for those examples of how information science and good policy can coalesce to go forward. But that kind of example of, like, we have been able to do it is proof point that we can do it again.
Thank you.
Hi, my name is Marshall. I'm a medical student here at Creighton. Last year, an organization I was with helped eliminate $2.2 million in medical debt here in Nebraska, as well as, we did a lot of research as a part of trying to oppose the big, beautiful bill. And, one stat that keeps coming back to me is that, some 66% of personal bankruptcies are related to medical debt and illness. And, it's not just uninsured or underinsured people that are dealing with this. It's people that are insured that still are not able to make ends meet. And so, this organization I'm a part of, Students for National Health Program, I mean, obviously the overarching goal is universal health care, which I think realistically over the next 3+ years is not a reality. But, I think I say all this to ask, what role do you think universal, like truly universal healthcare has in this movement of health reform? I guess I just want to know kind of what your opinion is, because we talked a little bit about a public option. I've had a hard time also resolving the statement that, we're going to get just as much opposition, or it's just as hard to pass small as it is big reforms, but then also trying to just improving the systems we have in place, right? So can you kind of help me resolve those two different things in your opinions on truly universal healthcare, like
Yeah.
Medicare expand?
No question. Do you have a definition of true universal, just out of curiosity?
I mean, I think, looking at some of the bills that have been put forth into Congress by Pramila Jayapal or, Bernie Sanders, that essentially everyone would have coverage, regardless of whether or not, I guess, you were signing up for it, you would be able to go in and get care, right? And it's privately delivered, publicly funded, single payer.
Yeah, and just so you know, there's like variations on
Yeah.
publicly funded, privately delivered, because Medicare is medium privately delivered depending on the state. I'm gonna take the goal from the how, right? The goal of saying that if you are a resident or citizen or whatever the term is of the United States, you should be able to get coverage is something that I think is the definition of universal coverage. It means that if you go and need preventive services or sick care or hospital care, there is some form of coverage for you. That's means universal coverage. I think that's achievable. We came close to it already, and it's going to go way back now. But I think when we came close to it, it remained, again, going back to your medical debt point, people had coverage, but the cost remained a barrier, prior authorization remained a barrier. We had barriers within the universal coverage system. And if you look at any other nation, including people with Medicare, we have those barriers for them too. You have to improve both. Getting them the coverage, making sure the coverage is sufficient, adequate for basic access to healthcare, right? How you do it, like, again, I worked hard on, a Medicare buy-in program, drop Medicare age eligibility down to age 50, having a Medicare-like plan offered alongside private insurance plans. We almost got that into the Affordable Care Act. Work with states that have been doing that because it's been happening. And, it's got to be a pathway there, right? How do you go from here to there in ways that make sense? And I think that people can chart them out in a way that makes sense. It takes some time. Again, even the ACA took like 4 years for us to get from like where we started to where we need to be. And then even then it was too quick. I'll be honest. But people can do that. I think, I'm gonna go back to 2020 because I remember Kamala Harris and Bernie Sanders arguing about the pathways. How do you get from here to there? Because that's exactly, they both agree on Medicare for all. There are ways to do it. I think you have to just go back to situationally, momentarily, what's the right way to go? And I will just say, Medicare needs to be fixed too. Like if you don't have Medicare Advantage, you don't have Medigap, you don't have Medicaid, it's a 1965 program. So we have work to do there too. That's a long way of not really directly answering your question, except I think universal coverage is possible. I think we just need to be more aggressive, smart about getting there quicker.
Thank you so much for the presentation today. It was really enlightening. And this question comes from a big dreamer person. So my question is, so that securing even small changes can be difficult, for small or large changes can be difficult. So from a policy strategy standpoint of view, how will future health reform efforts will balance the pursuit of improvements with a push for more comprehensive reforms?
It's a great question. And I think it could be, again, I'll call it, there's a difference between a dead and incremental proposal that's good for what it's going to do but doesn't go any further, to an incremental proposal that is on the pathway to something bigger. And I think that's the sort of thinking you have to do. And a good example is back in 1989, when George Bush was president, there's Democratic Congress, they wanted to cover more kids. So what they did was say, okay, our only way to get the Republican president to sign this is to say that a kid age 6 will stay on Medicaid until they're 18. So every year, 7-year-olds and the 8-year-olds and the 9-year-olds, and at times it felt really unsatisfactory. It's like so slow, take us so long to do it. But we got there and then keep going. They covered kids below 6 up to 133% of poverty, then 138% of poverty, then covered all kids there. Then the Affordable Care Act came along and tried to make all adults up to 138% of poverty, almost got there, might get there again. That's a way of being strategic. Medicare buy-in is another one that people thought would be a way to get the foot in the door. Having employers be able to buy into Medicare, I think is an even better way. Employers are really frustrated they pay the most, self-funded employers pay the most of anybody in this country for healthcare. It's a little known secret. People think employer-based coverage is great. It is great for you, but it's the highest paid, most expensive insurance in the country. Like, can we figure out pathways that way? So it's a matter of identifying options, working them through, then figure out, again, being a little agnostic about how they come together, but keeping an eye on the whole.
I'm going to ask the last question here, and then I'll encourage those in the room to bring your additional questions into the next room where we'll have refreshments to share while we're continue talking. But as a last question, I'm curious, we sit here at Creighton University. You work in part at a think tank. We have other think tank leaders in the room, and the Institute aspires to being a thought leader. What's your sense of the role of academia, think tanks, and healthcare professionals in being change makers in this period of time where evidence still matters, but is received differently?
I think it's enormous. And I will say to everybody in this room, the fact that you're here asking good questions engaged is a big first step. So this is where it begins. It begins in places to share ideas, share lessons. You can reject them. I mean, you can say the Affordable Care Act made things more complicated. It didn't do enough on the mouth. Yes, the answer is yes. It did other things well. We learn from that. We learn from the mistakes and then figure out how to get together. But I am convinced that having done the thinking part of it means that when you have that one chance to make a change, you do it better. And the better means it's as effective as you want it to be, it's as efficient as you want it to be. People see it work and they want to build on it. That to me is what groups like this can do. And it happens in dialogue. And I will just say, now that I've thought about it, something I was trying to express earlier with your question, Malcolm, about coverage. It's about what can you do at a moment, as big of a thing you can do, as bold with vision as you can. What that looks like may be different depending on the moment. That's, to me, I think, the harder part. It's not something inpatient people like me like, because I'm not a patient person, but it's the way all big changes work in this country, and it's the way it's going to work again. And especially in a world in which we have a lot of different forces out there, that vision and focus is going to be what matters.
All right. Well, thank you so much. Join me in appreciation for Dr. Lambrew being here.